Good afternoon, ladies and gentlemen. I'm Michael Wang from MD Anderson Cancer Center. I first want to thank Dr. Bill Harry to invite me to this wonderful meeting. This is my first time ever in Indiana and the first time ever in Indianapolis. I also know Steve Coultry, Dr. Coultry, and we used to be met in advisory conferences. And one time I met him, we were both at the same conference forgot the country, Argentina. And we compare our notes of mantle cell lymphoma and CLL, the similarities and differences. Today, I'm going to talk about mantle cell lymphoma. As we all know, mantle cell lymphoma is a rare disorder. It's only account about 6% of the non-Hodgkin's lymphomas. So here are my disclosures. So when a patient comes to you with a diagnosis of mantle cell lymphoma, it may be the patient was never treated. It was newly diagnosed, and maybe the patient was treated by somebody else and have relapsed mantle cell lymphoma, and I ask you for your opinion. First of all, we need to pay attention to the patient's age. Please remember, we artificially divide the patient into older population and a younger population using most frequently the age of 65. A lot of European studies use age of 60. But please remember, this is not a very strict number thing. If you have a 70-year-old who is performing well with no comorbidities, you can treat him with therapies for the young people. On the other hand, if you have a 60-year-old with poor performance, comorbidity severe, and you need to be careful with treating him with young therapies designed for young patients. Second, you need to realize whether the patient has any urgent symptoms or not, whether you send the patient directly to ER. I one time saw a patient whose WBC was 400,000. And so I talked to the patient. I see the fundus has some bleeding. I sent the patient to the ER and did a PE protocol. The patient has a PE. And a big, humongous PE, and it has been there for a while. Please remember, a huge spleen from mantle cell lymphoma, oftentimes the infarct with a severe pain. And if the patient happened to have trauma, fell from a bike, or the grandson jumping on him, he can have a ruptured spleen. Because the spleen could be up to 30, my record is 32 centimeters, okay? So whenever the spleen is over 20 centimeters, your urgency need to kick in. Of course, we need to pay attention to the patient's history if the patient has relapsed, whether the relapse is aggressive or not. Please remember, mantle cell lymphoma is 2% of the time aggressive. Only 1/3 of the time relatively indolent. And the indolent classic variant can transform during the therapy. The p53 mutation, usually 15 to 20% in newly diagnosed untreated patient, it goes all the way up to 70 when the patient has 3 or 4 therapies. Initially, the p53 mutation may not be present. They can transform to acquired p53. Initially, the patient may be classic variant, diffuse nodular. They can transform into pleomorphic and blastoid origin. We also need to pay attention to the factors that can change our therapy. For example, the patient have a small non-bulky disease, but he has clearly have a p53 mutation. You probably should not watch and wait for this patient. And so many other things they're important. There's controversies in everything we do for mantle cell lymphoma. Why? Because it's such a rare disease. We rely mainly on phase 2 studies. We don't have many phase 3 studies until in the past 10 years. We have some phase 3 studies, but the majority of the therapies in the NCC guideline, they're based on phase 2 studies, and the NCC guideline, they lie over there. They don't tell you which one to use first. which time to use late. So it's very important. Please remember, do not use R-CHOP therapy for your newly diagnosed patients anymore. Many studies have shown that R-CHOP is inferior to bendamustine rituximab. So the most commonly used therapy for elderly patients with a newly diagnosed mantle cell lymphoma is bendamustine rituximab. However, that has just changed a month ago when the ECHO study using BR plus acalabrutinib showed a very significant PFS. I'll show you the trial later. But please remember, if you use BR, it's no longer the standard. The new standard is acalabrutinib plus BR. So number one, do not use R-CHOP. Number two, BR is phasing out. There's new standard therapies, bendamustine rituximab and acalabrutinib. If you use BR, years later, the patient question you, why didn't you follow the FDA approval? And the phase 3 trial showed putting acalabrutinib is better than BR. Why are you still using the BR to treat me? You would not have a lot of defense for yourself. So the green part at MD Anderson is trials at MD Anderson. We are doing rituximab, pertobrutinib, we do rituximab, pertobrutinib venetoclax, and we have just finished a trial of enrollment on the Traverse trial sponsored by AstraZeneca. And all for trial therapies, we use basically the red. We advise to use BR minimum. The other ones, and I think it's no longer be the standard. Now, if the patient has high risk, so high risk, if you saw the publication of Dr. Jane, Peter Jane, and me recently in Blood, we have listed 30 risk factors. It's very hard for you to remember because you do not only treat mantle cell lymphoma for a living like me, you have to treat other diseases. So it's very hard to remember. Please remember, p53 may not matter in other diseases in terms of data management. p53 is a very big factor. Please remember, KIC7 over 50 is also very important to remember. That's high risk. And then the blastoid and pleomorphic. Any of the three factors present, you may want to use some chemo-free combinations. For example, the second online here, the Bowen study. The Bowen study used zanubrutinib obinutuzumab venetoclax designed just for P3 patient with newly diagnosed mantle cell lymphoma. That has shown, that's led by Dr. Kumar in Memorial, and it has shown a very good promising result. So here is the ECHO study. A lot of people already know what is the ECHO study. Basically, it is designed to answer this question. In the experimental arm, you can see the upper arm, your patient received bendamustine rituximab and rituximab maintenance. On top of that, the patient we add acalabrutinib to it. In the placebo arm, you just receive BR, rituximab maintenance, and placebo. The result is that the overall response rate is similar, and the CR rate is a little 13% higher in the acalabrutinib versus the placebo. However, the PFS are statistically significant between the two arms. Therefore, adding acalabrutinib to BR versus BR placebo, there's a statistical difference with the PFS. So please remember, 70% of the patients in the placebo arm, after they are unblinded, they received, if they was not received on the acalabrutinib arm, they received the acalabrutinib sponsored by the company. So this means a lot of people ask me, Dr. Wang, why don't you use BR and then use rituximab acalabrutinib when it relapsed? This curve answers that because even with the 70% of patients crossed into the placebo arm, the PFS is still significant. This means concurrent therapy with acalabrutinib BR is better than the sequential therapy. And different from SHINE had also the same PFS difference, even wider. However, SHINE, the two curves close together,
and the overall survival was shown no difference, and then the international study Shine, after so much money, so much effort, led to the disapproval of ibrutinib. So ibrutinib is no longer approved in the U.S. It's approved elsewhere in Europe, but not in the U.S. for mantle cell lymphoma. However, the ECHO study is different. The ECHO study showed there's a trend, but no statistical significance. How about the controversies in patients less than 65 years old? The young people, what are we going to do? Please, the difference in the older and the young is that in the older patient, they can not only tolerate the superficial therapies like R-CHOP, R-bendamustine, R2, you add in collaborative to BR, but for the younger people, we used to have two therapies, intensive therapies, with the Nordic therapy, which is 6 cycles of R-CHOP alternating, 3 cycles of R-CHOP alternating or DHAP for 6 cycles, followed by high-dose chemotherapy or stem cell transplant. That is too intensive. A higher rate of secondary malignancy was reported up to 10 years. We also use hyper-CVAD because both these regimens cost overall survival more than 12 years. So even 20 years ago, we used stem cell transplant, we used hyper-CVAD. The patient, of course, go through all the tortures of nausea, vomiting, big catheter infections, loss of hair, no blood counts, infections, and they could still live. If they survive the therapy, they still live that long. So therefore, therefore, there's in order to challenge that, we have the triangle study led by our European colleagues. It showed that whenever you added the ibrutinib to it, here's the triangle study. So arm A is the standard therapy, 6 cycles induction therapy follows the stem cell transplant and observation. And the second arm is the same thing, but you add the ibrutinib. And you still get the stem cell transplant. Arm 3 is the same induction therapy added by ibrutinib to the induction and to the maintenance without any stem cell transplantation. What happened? So you see the blue curve that's inferior. That is the standard therapy with 6 cycles of induction therapy followed by high dose and then autologous stem cell transplant. This underperformed with ibrutinib added to 6 cycle induction, followed by rituximab ibrutinib maintenance. So if you add, basically, I think triangle study is a success of the maintenance. People don't realize that we know that myeloma maintenance is very important. People don't realize that the mantle cell lymphoma, the maintenance is also important. So we have all those data trials of very few times we can cause overall survival difference. What happened to the Lima trial is Lima trial headed by Dr. Luhua, the French colleagues. They lead a trial called LISA trial long time ago, and it showed that rituximab maintenance can prolong not only PFS, but overall survival. That maintenance added to bendamustine, BR after R-CHOP, maintenance added almost to everything, improved the outcome. So maintenance is mandatory in mantle cell lymphoma, especially for the high grade. So the triangle, I think, is the success. The maintenance actually got rid of stem cell transplant. So, but I still think that in the future, we need 6 cycles of chemotherapy with cisplatin and it's phytosteroids, RC is still very toxic. I think triangle study may help us already stop doing less stem cell auto transplants, but in the future, we should be looking at the future studies, the chemo-free studies. So in these chemo-free studies, we have basically currently 3 choices. One choice is acalabrutinib, venetoclax, rituximab. I have led with my colleagues a small clinical trial that enrolled 21 patients. And we have an overall response rate of 100% and CR at around 90%. However, 5 patients died from COVID out of this 21. And the majority of this patient was not vaccinated.
So please, if you ever see one of your patients did not have a vaccination, you should not give the therapy. You should ask the patient to do the vaccination immediately. You know, those days everybody gets vaccinated, but still, I still see some patients, they refuse the vaccination. So they cannot survive me. They all get the vaccination after they saw me. So we are talking about the infections after the CAR T-cell therapies, okay? Well, I might as well just tell you, infections is very, very, is happening like, you know, our toxicities, you have headaches with the club burn, you have atrial fibrillation with the eye burn, you have many. But infections usually is the most common thing. It's not only the COVID, it is the viral viruses. You know, I'm working with the doctor, Beduna and Pablo Beduna, who actually is from Indianapolis. He called me, and together we diagnosed with West Nile virus, and unfortunately the patient did not survive. So the three chemo-free therapies here, AVR, acalabrutinib rituximab, and ZVO, which is the bovine study, and then the AR2, the Cornell regimen led by Ranja, is acalabrutinib rituximab R2. But you know, I developed R2 in mantle cell lymphoma. I think the Revlimid cannot be totally chemo-free because it has the properties. It decreases the platelet, can cause pancytopenia, and most importantly, in the randomized myeloma maintenance therapy on 3 separate trials, Revlimid, lenalidomide can cause secondary malignancies. So it's very hard to see that lenalidomide is a chemo-free drug. We talked about the triangle. So my treatment to the patient, to younger, is I'm using chemo-free therapies. After I finish the window 1, window 2 study, which I have not have time to talk about it, and based on all the 3 chemo-free regimens that I'm using chemo-free therapies. So I might as well, AVR was proved to be good in the small trial. It led to an international trial with international centers by the name of Traverse. We just finished the enrollment, and so far the result is very promising. This is the small trial. So trial therapies for relapsed mantle cell lymphoma. So I really think clinical trials is the answer. We have the BTB degrader. I saw a lot of data from Dr. John's slides, and we have the 417, the BCL2 Beijing degrader. We have epicoritinib trial, glofitamab trial, polatuzumab, mosunetuzumab, very, very effective, okay? So of course, we have CAR T-cell therapy, CAR-NK therapies in trials at MD Anderson. Off-trial therapy for relapsed lymphoma, keep in mind, if your patient has the aggressive disease, please try not to treat them with targeted therapies. Please use immunotherapies. So far, with all the data, CAR T-cell therapies are the best data. So you try to deliver the therapy when the conditions are right. So then you can use monoclonal bispecific antibody to rescue them. This is how I am doing. And so I think it's important that find the best opportunity as early as possible to give the patient CAR T-cell therapies. And bridging therapy, my favorite bridging therapy is hypercytoxan, dexamethasone, rituximab with the concurrent radiation. Please remember, aside from large cell lymphoma, the majority of lymphoma therapies, lymphoma, myeloma, they're equally sensitive to radiation. So if you might take 8 cycles of hyper-CVAD to shrink the mass, but if you give cytoxan, dexamethasone, rituximab concurrently with the radiation, I almost get a 100% response to bridge the therapy into CAR T-cell therapy or bring the patient out of trouble. With so many FDA approvals in mantle cell lymphoma, we have lots of combinations, so please remember that. Unique presentation of mantle cell lymphoma include extreme lymphocytosis, CNS mantle cell lymphoma, mantle cell from the testicles, in adrenal glands, in thyroids, tear ducts, and most recently, last month, I have a mantle cell in the heart. So special controversy in watch and wait. And we're not talking about the challenges. You can read the slide, which should be available. And thank you for your attention.